My name is Jim McGreevy, and thank you very much. I have a very special guest today, Dr. Chris Pernell. So welcome with Second Chances with Jim McGreevy. And Doctor, you were just extolling. Could you please share where you just came back from?
Sure. I just came back from Howard University, HU, in our illustrious nation's capital. We were dropping off my niece, namesake, Timmy Chris, for her first year of college at Howard. We're very, very proud.
And you should be. And what is she going to study? Does she know yet?
She's majoring in English with a concentration in creative writing.
That's impressive.
Yes. Very, very creative, visionary young mind. So I'm excited for what the future holds.
But English is also a rigorous.
Yes, very rigorous. And Howard has a very strong English department. So
I know they do.
For her to be shaped by those scholarly, empathetic, and historic minds, and what's going to be the outcomes of it. So Stay tuned, world.
You must be excited. So why don't we start, you talk a little bit about your upbringing.
Sure. So born and raised in East Orange, New Jersey. My parents both came from Virginia. They came of age during the Jim Crow South, and their parents very much were stalwarts in community. Both of my parents come from a strong tradition of faith. My father's father was an apostolic Pentecostal bishop who had ordained churches, over 300 churches throughout the South, before settling his own church home in Richmond, Virginia. And my mother's father was a community Baptist preacher. And so both of them grew up with very strong principles about faith, about community, around service, around servant leadership, if you will. Yeah. And that's who raised me. Neither of them had gone to college, right? Facing the realities of prejudice and discrimination and racism and a constraint or lack of opportunities, but they were very, very innovative persons. My father in math and science, he had started at the famous Bell Labs cutting grass, if you will, and went from cutting grass to becoming a member of technical staff, which is typically reserved for those with master's and PhD level work. So my father has contributed to great discoveries in science and engineering. And my mother, I tell everyone, she had a PhD in love, and was the neighborhood mom who took everyone into her home, who took everyone into her kitchen, and then turned that into a career in early childhood education. So those two people raised me and reared me, 4 of us in total, that, we would have to strive for justice. We would have to strive for excellence, and we needed to leave our community and our world better than we found. So that's where I grew up, in that household, strong tradition of love. And from East Orange, I went to Princeton University. Princeton took 2 years to work.
What was Princeton like?
Wow, what was Princeton like? You hear sometimes some very difficult truths about Black and brown persons' experiences at Princeton University. I went to Princeton in 1990.
And Michelle Obama?
Yes, she has been forthcoming about some of the challenges and the barriers that she had on campus, which were in contrast to some of the experiences of her brother Craig. But I went to Princeton from Glenridge High School. I was a tuition student at Glenridge High School. So going to Princeton was in some ways me having a more expansive community, because I felt very much under the microscope in high school, because it was a very small and sometimes isolated community. There were challenges, definitely. I had to demonstrate and prove that I was brilliant enough to belong, but not only was I an academic scholar, but that Princeton has a strong tradition around service and around leadership, right? In the nation's service, in the service of all humanity. So that meant me learning to leverage my voice on campus to change things that weren't as inclusive or didn't have a culture and a spirit of belonging as they should. And still today, you have Black and brown students who are travailing, who are laboring, who are agitating for justice. So it is a work unfinished, but a work in progress.
Hey, how did you find Princeton?
Very, very, very interesting. So I knew that I wanted to be a brain surgeon. Neurosurgeon is a technical term, since very young. Okay. I had a woman come to my school, Elmwood Grammar School at the time in East Orange. And I loved my grammar school. It was beautiful. We saw Black faces primarily, and as our educators, as the leaders, we learned about Black history. We learned about American history. We were told we can become and do anything in the world. And so it gave me such a strong foundation. So we had a guest speaker, and she was talking about all the different careers under the healthcare or medical umbrella. And she mentioned a brain surgeon. And my young, precocious mind latched onto that idea. And I found out about Dr. Benjamin Carson. I learned about Dr. Alexa Kennedy, the first female Black neurosurgeon. And so I remember telling my parents, if I'm going to become a brain surgeon, I started this in the 6th grade. I said, if I'm going to become a brain surgeon, I must go to the most rigorous and competitive schools possible so that I can compete at standard. So that's how I ended up at Princeton. I applied to a host of competitive schools, UPenn, UVA, Duke, Princeton, and Rutgers. And I got into Princeton and I visited. I got in everywhere I had applied, but I got into Princeton and I visited, and I knew in my spirit that's where I belonged. I felt it when I was touring.
So it's probably politically incorrect.
Home.
It's probably politically incorrect to say this, but Princeton's gorgeous, Chris. I mean,
yes,
like the buildings, it's idyllic. It's
overwhelmingly gorgeous.
Yeah, it's almost like a classic English.
Yeah.
I just found it, and I don't know whether this is wrong. I found it very waspy in the sense that I just found it to be, maybe this is very unfair, but old money. And it just, I wound up graduating from Columbia, and Columbia was like New York, and it was gritty, and it was like, wherever you were from, you were sort of, it was an element of climbing. And
and you know what? No, I'm glad you said that, right? Because we have to have these type of authentic conversations. And so I want everyone to imagine, here I am.
I always felt uncomfortable at Princeton.
Yes,
I felt like
because when I visited Duke, ultimately Duke became another one of my alma maters. I went there for medical school. But when I visited Duke for undergrad, I had very much the same impression that you just described of Princeton. And I said, this place is not for me. It felt very separate, meaning that the student body and the student population, I felt that they were emphasizing, the Black students here enjoy being here, but it almost felt performative in the way they were describing it and not authentic. And so people are probably wondering, well, why didn't you feel that at Princeton? Because I really believe I was supposed to go to Princeton. And you have to understand, I came from a household where I was reared in the tradition of Black excellence. I was reared in the civil rights struggle. My father marched on Washington. My father listened to Malcolm X at Brownstones. My parents were in and of the Jim Crow South. They were a part of that great migratory pattern north, fleeing the tyranny of segregation and looking for economic opportunity. And so I never questioned my identity or who I was. I was told that I was a trailblazer. So in wanting to be a trailblazer, I knew that I would be in environments where oftentimes there would be few people who looked like me, but that there was some mandate, if you will, personal to my family and a part of my people's struggle to change those types of environments. And so when I went to Princeton, I was coming out of Glen Ridge. And what you described about Princeton is exactly what I felt about Glen Ridge, but I felt it at a heightened sense because it was such a small environment. There were less than 90 people in my graduating class in Glen Ridge. Glen Ridge is, for others who may not be familiar with it, it is a predominantly white, higher socioeconomic suburb in Essex County. And I found it to be very
I think there are 3 Democrats. No, I'm only kidding.
I found it to be very isolating. And if I can use this word provincial at times, they did not have an understanding of the world about them, even in Essex County. So here I was, a young student in that environment. So Princeton was a breath of fresh air because I felt like there were other students like me at Princeton seeking to make it a more inclusive community, seeking to make it a place where we all could belong. It was not perfect. I don't want anyone to think my Princeton experience was perfect, but it was a part of my journey.
But it's a great university.
Yes. And there's a lot of focus on you as an individual student. I tell people that is a distinct difference in Princeton and a lot of its other peer institutions, where at some of those other peer institutions, there is a sentiment that the focus is more on the graduate student bodies, what their graduate schools produce, whereas at Princeton, there is an immense and intense focus on cultivating you as an individual.
As an undergraduate. Yep.
Yes, from the moment you step foot on campus and you're exposed to brilliant minds. Look, my professor was Cornell West. Toni Morrison was my professor. I was on campus. My physics professor had just won the Nobel Prize. So you were exposed to brilliant minds and you had access to that. And I was determined to make sure I left that place with all the tools and all the know-how necessary to change the world.
Interesting. What leadership lessons did you learn while at Princeton?
Wow. So I led the Black Arts Dance Company or Black Arts Company. And I had joined it as a freshman or first year, as we now say, and under the tutelage of others ahead of me, Bernadine and then Erica. Here were these brilliant, beautiful, predominantly Black, but Black and brown students who had careers sometimes outside of academics in creative arts. Some were classically trained ballerinas, others were trained in modern dance, you name it. And so we came together to create space for joy, to create space for expression. But oftentimes I felt that we were overlooked on the Princeton campus, that we had to fight to have equal and even equitable access to performance space, to opportunities to showcase what we brought to the community. So I would have to advocate for our group, our organization, before deans and other leaders in the administration to ensure that Princeton was open for all, but because it didn't feel that way. I mean, we were fighting for places to practice where other groups had, carte blanche access to those studios. And so that was one of the ways that I led. And then in another way that I led was definitely through my faith, my worship service. We had a hallelujah worship service. And I call it mine, not meaning I started it, but it's where I was able to come of age in many ways in my leadership in faith, helping to organize services or standing out and proclaim. Yes, I feel a call on my life to serve in the Christian tradition. So between those types of activities, those people activities, other times you hear people say extracurricular, but they just felt like activities to engage with humanity. I really started to use voice, and I use voice as my power, and that power as my lane for leadership. And then from there, I entered ministry almost immediately upon graduating from Princeton, because my brother, Bishop Pernell, had started an assembly. So while I was prepping to go into medical school, I was on the front lines of ministry, but I really started to nurse and cultivate that seed at Princeton.
And I love who your brother is, and that he's unapologetically Christian and proud. And so anyway, so that's Princeton. So then you go to college. So you apply to medical school, right?
Yeah. Mm-hmm.
And Duke's a great medical school. Princeton is a great college. I mean, it's arguably they're both like why Duke?
So I didn't want to go to Duke. I am the person, and I want people to hear this. Life does not have to happen in a linear path or trajectory. And through setbacks and through disappointments, through closed doors, we oftentimes are given an opportunity to reinvent who we are, or we're given an opportunity to own the fullness of who we are. So I told you earlier that I wanted to be a brain surgeon. I literally wanted to be the next Dr. Benjamin Carson until I came of age and learned I probably am better off being the first Dr. Chris Pernell. But I wanted to be him. I wanted to walk in his footsteps. So I wanted to go to Johns Hopkins, and I didn't get in. I applied multiple times to Johns Hopkins, and I didn't get in.
Well, eventually you got there.
Right, yeah, but this is a story. This is what I want people to hear. And I couldn't understand why I didn't get in. I was like, look, I'm competitive. I'm graduating cum laude from Princeton. I was praying over this. I was, really hungry for this opportunity, but I was merely imitating someone else's journey and not necessarily owning my own journey. And so finally, and I don't recommend people do this, like I turned down acceptances, UVA, Tufts, Michigan, a host of New Jersey medical schools because I was trying to get into Hopkins. And my father said to me, "What is wrong with you? Are you going to go to medical school?" I was, yes, not quite as wise as I am today. Like we keep growing, right? Our wisdom grows, hopefully, and accrues through years and experiences. But my bullishness about going after Johns Hopkins is actually, Governor, what gave me 2 years to work on the front lines of ministry. And you would find me on Broad and Market. You would find me working with youth who were struggling because of the oppressive systems of racism and sexism. You would find me wherever people were in need. And ultimately, that after that third cycle, so I set out 2 cycles intentionally. And after that third cycle, I said, okay, I'm going to go to Duke. Duke was at that point the number 3 ranked medical school. My grandmother lived nearby. And I said, Yahweh, if this is the path that you are commanding me to walk down, then I will walk. I took a very long and painful train ride to Durham, North Carolina, with tears in my eyes because I said, oh, this isn't Johns Hopkins, and I want people to hear this. And when I got there, there was still a sense of sadness that my life had been redirected and I wasn't quite sure what I was walking into. But think about that. Here I was at one of the top medical schools in the nation, but I still wasn't satisfied because sometimes what's motivating us isn't the truest path to our purpose. And so within 3 days, I met my class. And this was the first time in my life I was ever educated in the most diverse environment. I mean, there was no majority in my class. I looked around and there were other Black students like me. There were Latino students. There were Asian students. There were Middle Eastern and North African students. There were people across various ages. And it was the distinct leadership. She's now deceased, and bless her soul, Dean Brenda Armstrong, who said to the Duke administration, if I accept the most diverse class that this school has ever had, I guarantee you they will be the most competitive. I guarantee you that they will make the most inroads into producing change in health and healthcare. I was a part of her vision. So Yahweh was redirecting me, and I didn't understand it at a time. And so it was the most beautiful experience for me to go to Duke. Because at Duke, my leadership went to the next level. I learned how to advocate on behalf of all of my medical peers to ensure that the Duke environment was more diverse and more inclusive. I sat on committees to name chairs to departments, was able to articulate the concerns and the challenges that Black and Brown students were facing, was able to begin in a very nascent way, understand health equity. Didn't know that's what I was doing at the time, but to begin the tools to build health equity. So that's how I got to Duke, and I loved it, and it was perfect for me.
And Duke's campus, like Princeton's campus, is
Duke's campus was modeled after Princeton, and I made the mistake. You can get a laugh out of this. So I visited Duke first when I was in high school, right? I was what you call an AP scholar. I'd scored, high enough on several AP exams. So a lot of colleges invited me to come visit. Duke was one of them. I saw Duke first. Then I visited Princeton, UPenn, and some others. And when I visited Princeton, I said on the tour, oh, wow, this campus really looks like Duke. And they were like,
they're like, no, Duke really looks like Princeton.
First of all, Princeton is older, and Duke was modeled after Princeton's campus. It was intentionally to look like Princeton. So that's my funny Duke and Princeton story.
So after Duke?
So after Duke, I went out west still thinking I was going to be a neurosurgeon. And I was at UCLA in my first year of general surgery internship. I had not matched in neurosurgery, very competitive field, but I did not want to stay at Duke because I didn't think it was the right environment for me. And I wanted to either go to Mass General or again to Hopkins. And something always kept getting in the way. And I had a very good mentor who was at Harvard, who said to me, Chris, take the intern year in general surgery and then do the match again, or come to Hopkins as a pre-residency fellow and do the match again. So I went out west, and actually I had an epiphany about the fall of 2003. I decided I did not want to be a brain surgeon. I had spent my young adult life since the sixth grade, preparing myself for that eventuality. And then I learned that I had greater tools than the tools of a surgeon. This is not to knock those who are surgeons, but I personally had greater tools. I had the tool to connect via heart, via mind, via spirit, to speak, to think about systems on large, and then to conceptually innovate how to improve those systems and to engage and interact with people. So I wasn't quite sure what type of doctor would use those skills. So it took me another, circular, very circuitous path to ultimately land in public health and preventive medicine. So I got additional training, and I got that training at Columbia to get my master's of public health in a very innovative track, seeking to train healthcare and public health leaders who wanted to redesign healthcare, who wanted to redesign public health in the United States. So I did that. Then I went to Johns Hopkins.
Before you jump, so Mailman is a great school of public health. And they've done some really progressive and thoughtful changes. If you were to look at the one policy change, and Mailman's been at the forefront, in my world on reentry and healthcare. What's the takeaway from Mailman School of Public Health at that point in time?
Wow, I'm glad you asked that, because I often laugh and I tell people that school was very expensive. I left that school with more debt, almost equivalent, I should say, debt, the 4 years at Duke. But I was supposed to go there, and I was supposed to go there at that time. So I was at Mailman from 2009 to 2011. And this is before PPAC or Obamacare had become law. This when minds across the nation and even the world, if you will, were grappling with health reform, health system reform, were grappling with the integration of public health and clinical care. So here I was at Mailman, when Mailman was deliberately digging into those issues,
questions,
right? And how do you redesign systems to meet evolving needs of populations, and especially historically excluded populations? So I was sitting in class with CEOs of hospitals. I was sitting in class with consultants from the top consulting firms. I was sitting in class with professionals from the NHS, right, in England. I was sitting in class with a diverse array of people, some who had left the finance industry to come into healthcare, because there was a lot of churn then. A lot of people were jumping into healthcare because we were like, we're finally at the cusp of building something in the United States that could potentially be health service delivery reform. It became health insurance reform, but that's where the gusto was. And Mailman really was at I would say, the epicenter of a lot of that activity. I had a faculty or professors who were either going through confirmation processes for the Obama administration, who were a part of the think tanks thinking through what healthcare of the future would look like. And I was blogging for the Washington Post myself, alongside Newt Gingrich and Howard Dean. Here I was, right? A doctor who had interrupted her training to jump into public health to say what was a part, what should be a part of future state. And Mailman was key and critical at that. It was seeking to identify and develop innovative ideas, and then to amplify those ideas to say, how do we change and redesign all of healthcare?
So that was a pivotal experience for you.
Pivotal.
And then Hopkins, right?
And then Hopkins, yes, because I had, again, going back to Princeton, I had a dear friend, Darius Clark, that I met at Princeton, and he said to me, I remember it because he inboxed me on Facebook, and he said, Chris, do you know what type of doctor you are? Because remember, I said I didn't want to be a neurosurgeon anymore, and I was trying to figure out what that was. So I started radiology training. And I was like, okay, I'll be a neuroradiologist, whatever. And he said, Chris, you're a public health and preventive medicine physician. I had never even heard anyone mention that to me.
Articulate that, yeah.
No, I started asking my friends. I said, have you ever heard of this? And only one person had. And so he was like, you should consider Johns Hopkins program. It's the best in the nation. And, Johns Hopkins really is the creme de la creme, if you will, of public health in the United States for many disciplines, especially at that time. And so I said, look, but I'm getting ready to start this program at Melman that I'm really excited about. He's like, okay, I understand you don't want to withdraw from that program. He said, but after that program is done, you need to find yourself to Hopkins. So that's what I did. I applied. I had considered.
So how would you compare Hopkins to Melman? How would you compare those two schools?
Wow. So because they served distinct purposes in my life, so I was at Columbia specifically for graduate work in the field of public health. I went to Hopkins to receive additional training as a physician. So one was specific to a physician population, and the other was just for professionals, graduate professionals in public health. And everyone in public health is not an MD, right? Or a DO. Everyone in public is not a medical physician. And so they serve distinct differences. But Hopkins is also known for its, full pantheon of public health academic prowess. And so what was distinct about it for me is that I could, operate at some of the highest levels of public health and public policy while at Hopkins, because it gave me entree and access to policymakers in DC at federal agency levels, right? So it wasn't just thinking through, and New York is a big lens, right? So it's no small lens, right? At Columbia. Was not just thinking through a local or a community or a state lens. I was doing it at every possible level under the Hopkins blueprint. So it gave me an opportunity to lead, but especially because I already had my master's of public health, to lead while still being trained, and to be a part of federal projects like with the Office of Disease Prevention and Health Promotion, to be a part of public advocacy with Public Citizen, to be a part of even local health departments and how local health departments utilize data to innovate. In Baltimore, it allowed me to come back to New Jersey to work at the Essex County Hospital Center, so to work with a psychiatric patient population. It allowed me to work at Rutgers School of Nursing with a nurse innovator who was showing how you could build community integrated care models. And so under that Hopkins banner, I just wasn't sitting in the classroom. You were
out in the world.
I was deep in the world, and I was building and creating new thought.
So we'll shift a little bit. Tell me some of the challenges in urban healthcare.
Wow. Okay. So during the COVID pandemic, I spoke about this topic a lot, and I think the easiest way, the easiest way for people to understand it is this: disparities mean unequal outcomes, right? So there are disparities
and access, right?
Right. I'm going to explain that. That, right? So so it's just like whatever the outcome is, it's unequal, right?
Okay.
Whatever the variable is, it's unequal. That's what disparate means, the disparities. And so often I had heard academic conversations around health and healthcare disparities. And oftentimes those disparities were stratified by race and ethnicity or sex or gender, right? Why do we see certain populations, especially historically excluded populations like Black or African American, Hispanic or Latino, saddled with these disparities? And I think the easiest way for people to understand why you see those downstream unequal outcomes are because of upstream conditions and factors. And we break it down at 3 different levels. The disparities that we see in life and in health and healthcare, in particular in the United States, are due to these 3 distinct levels, because there are disparities in access to care. That's one of them, meaning that not only in urban, but in even rural environments, right? We have to elevate these stories that there is less access to providers, not just physicians, but providers, right? So whether those are providers under the nursing, under the doctor, under the medical doctor versus, let's say, rural health banner, there's less access to high quality care. Where is that care found? And is it open during hours that are conducive to the lives and the livelihoods of the persons who are oftentimes saddled with injustices, whether historical or contemporary, right?
Yeah.
So, you know, there's a doctor's office, but you work until 6 o'clock and the doctor's office closes at 5. So how are you supposed to get primary care?
Yeah.
Okay. Right. So there's
disparities.
You don't. That's right. So you don't. So there's disparities in access to care. Then there are disparities in the level of care received. Okay. And I learned this best, unfortunately, through the experiences of my parents. I lost my mother to severe Parkinson's, and my father died from COVID, but my father had a host of chronic health conditions prior to being diagnosed with COVID. He was healthy when he got COVID, meaning healthy for him, right? The guy was always fighting back. But in the United States, we have separate and unequal care. Me as a Black woman, when I was at UCLA, I had suffered symptoms of postural orthostatic tachycardia since adolescence. It wasn't until I got to UCLA that I finally got it diagnosed. The experiences I went through to get that diagnosed, my symptoms weren't believed. They were not validated. There was delays in treatment. There were delays in getting me on the right treatment. I had to take a journal article into one of my doctor's appointments to say, listen to me, this is what's happening to me. I was told, oh, it's just in your head. You're just anxious. You're just stressed. I was told, oh, it's asthma. I was told, oh, it's a GI issue. No one would listen to me. And that was me, a Black woman physician with agency. Okay. So that's when I'm like, this is what we mean that people don't have access to high quality care. We see that in the abysmal Black maternal mortality rates. When my mother was struggling with Parkinson's and the host of complications that she experienced, I had physicians dismiss her from the ER, telling me there was nothing wrong with her, though we subsequently found a splenic artery aneurysm that was suffered because of a traumatic fall from a wheelchair. I had people yell out about my father in a local hospital here in Essex County, New Jersey. Watch out, here comes HIV, as he's being rushed into an ICU, as he's having a rupture of an aneurysm in his lung. Those are examples of disparate outcomes in the quality of care received. That's the next level of why we see the disparities that we see. And the last level, and this is, wow, I believe the most oppressive level, is the disparate access to life opportunities, meaning safe, humane, and affordable, high quality housing, high quality education, a living wage, open green spaces, healthy, nutritious food. If you don't have access to those things, you can't be a high functioning, whole, well, and healthy person. And because those are some of the larger, more complex and appearingly intractable social conditions that we're dealing with, those inequities are leading to the downstream disparities in outcomes that we're seeing. So while we're facing disparities in access to care, disparities in the quality of care, we're also facing disparities in access to life resources because of how those resources are distributed throughout certain communities.
So, I mean, it seems like obvious, but if you were to redesign the criminal justice system, particularly the delivery of healthcare, and you work to design and to write a tremendous report with Professor Pam Valera, Rutgers School of Public Health. And if you could take us through it slowly, 5 basic questions. One, what's your sense of the conditions of healthcare in our nation's correctional system? Secondly, what are the failures that are so evident? 3, what are the corrective steps necessary for what is the timeline to launch on those corrective steps? And 5, why aren't we doing it?
So let's go back to that lens that I started with at those discrete levels that disparities happen. So imagine that you're not only historically oppressed or systemically oppressed, but now you've been stripped of most of your human and civil rights because you're incarcerated.
Yep.
And I want people to start there, right? So it heightens all of those challenges that we just described. Care for incarcerated persons is more fragmented even than care for people.
I'm gonna take some notes, so go ahead.
People living outside of the incarcerated system. It's fragmented. And what is fragmented care? Fragmented care, it means that it's not whole person care, meaning it's not addressing all of the issues that are central or core to who you are as a human being. And as long as you have fragmented care, you're going to have disease and conditions that are either identified at a later stage, that are more difficult and more complex to treat, and then access to those services are going to be even more hampered because you're talking about a system that is not, it doesn't even have the same resource pool.
Yep.
Doesn't have the same resource pool, right? So in incarcerated populations, you are talking about people who are bringing to a jail or prison setting all of the life exposures that they have experienced prior to incarceration. Those life exposures have predisposed or has I would say heightened or increased their risk for certain health and life outcomes. And oftentimes, because there's fragmented care on the outside, they never even knew about those things. So imagine then getting behind the wall where care is even more fragmented.
Yep.
And trying to get things rightfully identified, diagnosed, or treated. Think about how difficult it is to get an appointment when you're not incarcerated, than thinking about trying to get that same appointment when you are incarcerated. You need to see a certain type of specialty care provider. You need to see a primary care doctor. Heaven forbid that you have a surgical issue, or that you're a woman or a person who is going through the birthing process, right? And so because we have a fragmented system of care, whole person care is not being effectively mediated for those who have some of the greatest burdens of need.
Yep.
That's foundation, right? So then you got to think, who is incarcerated? Who are these populations, right? Who are these people? Who are they comprised of? And do we have resources specific to their needs? So let's talk about women, or those who identify as women, and whether or not they're getting specific care around reproductive health, whether or not they're getting specific care around maternal or birthing needs, whether or not they get timely care and high quality care, whether or not they are people who have chronic health conditions while being in a birthing stage, and whether or not those chronic health conditions have been appropriately treated and mitigated. So if they have not been, they're worsening during that time because they don't have access to whole person care. Yeah. Imagine experiences that they had prior to getting incarcerated, exposure to rape, exposure to sexual abuse, exposure
domestic
to
violence, sexual abuse,
domestic violence, intimate partner violence, right? The trauma that people have been exposed to in their lives.
For a woman that we deal with, 2/3 of them have.
Yes. So then imagine being behind the wall that has an even more hyper fragmented care system and not having access to the resources that you need to meet the need of the patient population. And I want everyone to understand, equity and equality are different things. You can't just say, oh, let's just make it even. Whatever the resources are outside of a jail or a prison, let's have those same level of resources inside. No, resources have to be dictated by the level of need. And the more desperate the need is, because the more burdensome the exposures have been, the more resources we need focused on
Are
those
required.
and we don't have them. We don't have them, Governor, or we have them in a protracted, fragmented way. So you're not getting person-specific care. In healthcare, we say that the person should be at the core, and that all health and life-related activities should revolve around the person. When the person is not at the core, right? You tell the person, oh, this might not be specifically what your issue is, but this is what I have available for you.
Yep.
And that perpetuates disability, that perpetuates, or we say in healthcare, morbidity, that perpetuates mortality, and that does not allow for rehabilitation, right? So because of those traumas, those persons are also burdened with co-occurring disease. What's co-occurring disease? Whether a person has a psychiatric diagnosis, right, some mental health or mental illness, or if they have a behavioral health condition, substance use disorder, as a way of coping with the traumas of their life. So again, if you don't have whole person-centric care, and you have a fragmented system, those people who are approximating the cliff fall off the cliff.
Fall off the cliff.
They just keep falling off. They keep falling off. So being incarcerated worsens their health.
Sure.
Ages them prematurely, and heightens their mortality risk, right? So I would say then, if you want to begin to think about, right, what are the types of corrective actions and what's the timeline for those actions, we need to have parallel interventions and efforts. And I say parallel because right now we're having more honest conversations around how do you drive health equity in health ecosystems. But we have to have those parallel conversations for those behind the wall. We cannot allow people who are incarcerated to remain forgotten, because it only amplifies the issues that they're grappling with. Should they be reentering society, those become more explosive, and the family members of those who are incarcerated continue to suffer disproportionately, right? So we have to talk about in parallel, how do you drive health equity for the justice involved community,
population, sure,
or their family. How do you drive? And a lot of that is going to say, do we understand their needs? Meaning, do we appropriately understand the risk factors that are contributing to certain disease patterns? Do we understand the needs specific through the lens of who they are culturally, who they are socially, who they are from a gender and a sexual identity standpoint? Do we understand their needs clinically, right? And I just gave an example of co-occurring disease. So while we're having these health equity conversations outside of incarcerated settings, we need to have amplified, vigorous conversations of those who are incarcerated around how do we ensure that they get access to high quality, socially, culturally fluent, whole person-centric care. And that, my friend, takes political will. That's political will. And the example that I will give people is the pandemic. So when people were dying at an alarming rate, or getting sick at an alarming rate, there became, unfortunately, almost a survival of the fittest mentality in certain aspects of our society and culture. But as people began to beat the drumbeat of no, we got to think about this through an equity lens, people who were already saddled with injustices don't have access to the care that they need, and they're dying at proportionate rates. Then you heard people say, well, what about the people who are incarcerated? If this is happening,
wasn't that a high watermark?
Yes, that was an example of how equity gives way to justice, right? And I tell this to people all the time: equity is not the end. Justice.
No.
All human beings deserve justice. Right? And so then we began to have conversations about, okay, are we ensuring that those who are incarcerated are safe? Are we ensuring that they have access to PPE? Are we ensuring that they have access to providers. Then you had conversations around compassionate release, right? Or early parole, like persons who are incarcerated who don't need to be incarcerated because the risk of mortality and morbidity outweighed a risk of releasing someone back into the community who was unsafe or who wasn't ready, right? You wanted to think through who.
Well, can you just jump in and tell me about how you changed the test?
Yes.
For Essex County, because I think this is so important, is that, Chris, you serve as a volunteer, as a physician, as an educator on the Essex County Civilian Task Force. And I think the two changes that you proffered during COVID, particularly as it applies to the testing protocol, was invaluable. Could you?
Yes. So I would say the quickest and the most direct impact were the types of tests that were available to those who were incarcerated in the county jail. At that point, data and our knowledge was quickly evolving. And I don't think everyone understood how to use, let's say, antigen based tests or molecular tests and antibody tests, right? And so the jail was like, oh, we were checking for antibodies. We're checking to see, who had certain.
Can you just explain the difference for our audience between the two?
So one could just indicate exposure versus active infection, right? So perhaps you had been exposed to COVID at some point, right? Versus being able to identify someone who was going through an active infection and needed to be isolated so that infection would not continue to spread, or to have access to treatment. So we were testing for the presence or identifying whether or not people had antibodies to COVID, when we should have been testing through an antigen-based test whether or not COVID was actively present and infecting the person. So that became a quick change that the jail did, and you could have rapid-based,
and that was to the credit of the jail.
Yes, you could have rapid-based antigen tests, right? That were these tests that could give you a result in approximately 15 minutes versus the gold standard serologies, again, which were tests that would take not several days. At one point, they were taking weeks. In the early parts of the pandemic, they were taking weeks to get results back, but tests that could take several days, some of them 24 hours, some of them 48 or 36 hours, to say, okay, this person is actively infected with COVID. Knowing that, then the jail already had a principle of quarantining everyone who came in, knowing that we knew specifically who needed to be isolated. We knew specifically if a person needed to be in infirmary, if a person was so sick that they need to be transferred. We knew immediately how to segregate the population, if you will, in a more effective way, so that we could limit disease spreading throughout the facility and get people.
Jails and prisons weren't designed to. Jails and prisons weren't designed simply to accommodate that protocol.
No, because jails and prisons, and I'm going to say this, and some people may balk of it, because jails and prisons aren't designed for rehabilitation.
No, not at all. Not at all.
They're designed at housing people.
I would argue at best.
At best, that's all.
Yeah. So
they're housing people. I think it's actually better than housing.
Yeah. So your experience on the task force, what do you walk away with?
So I think
when the scope of the challenge.
Yeah. No. And as a public health and preventive medicine physician, it is so important in our practice, right, to think about care through specific populations. In the more vulnerable or marginalized or historically excluded the population, the greater the need and the greater the demand for systems to be redesigned so people don't experience a loss of life or disability that impairs life. And so the task force has been an opportunity to help one of the most marginalized and vulnerable populations that exists in our community and society. And I'm looking because, I follow Brian Stevenson's work, and I have several of his quotes hanging all throughout.
I've got his, hey.
I'm like right there. I see it every time I go in my kitchen. And we have dehumanized those who are incarcerated,
On the head, right.
whereby it does not offend our humanity, our sensibility, that they are treated, maltreated, unfairly, unjustly treated. And so being on the task force is an opportunity to elevate the humanity
Yep.
of those who are otherwise systematically oppressed, right? And in doing that, it shows people that we don't have to lose sight of fairness in achieving justice.
Yep. So when you say you don't have to lose sight of fairness, yep. Thank you. I'll put my EJI hat on here. Yeah, and I have it in my office to remind me every day, you know, what we're about. So if you think about these issues from a healthcare perspective, Chris, but I walk in jails, whether you walk into Trenton, you walk into Rahway, you walk into Northern State. I mean, you use the word warehousing, and Governor Murphy, to his credit, has moved significant numbers of persons out, largely through COVID, largely through the support of legislative leadership. But our prisons very much look like prisons in the sense of a 18th century model.
Yeah.
I mean, you look at other countries and they look like condominium complexes trying to reward healthy behavior, trying to reward communal interaction, trying to reward the virtues of work, the virtues of accountability. And yet, you know, I could walk into Rahway, or I still say Rahway, East Jersey State Prison, or Trenton, and it's like I'm walking back 100 years ago. And in the case of Rahway, literally 100 years plus into time. And even with really the best of intentions and good people, what is it about, you know, and I won't rant, as my daughter says, but like, you know, every municipality has jail cells. Every county has, almost every county has a correctional center. The state has a series of prison complexes, and reentry has a foot. But why doesn't America, your sense from a health perspective, why doesn't America make a change that to me is so glaringly obvious and necessary? Like, why are we still in this place?
Yeah. Wow. And I have to take you back to Columbia. I learned health policy from the great professor, Dr. Michael Sparrow.
Yes.
Yes. And when he teaches, and I wish everybody, there are certain thought leaders that I've had access to that I just wish everyone had access to. When he teaches health
and who
policy,
was the assistant dean that was really great there? There was a great. He was the assistant dean, and for a while I think he was an interim dean, but he was a great thought leader on intersection of social justice. But anyway,
it'll come back to me. But the way Professor Sparrow taught us to understand health policy was understand how this nation was founded. Because the very principles, sentiments, and understanding around who was deserving of help, who was deserving of redemption, who was deserving of rights, the sense of individualism versus, collectivism, a sense of exceptionalism versus, again, collectivism. And so in the United States, there is a deserving poor and an undeserving poor. And so let me dig deeper on that. So in deserving poor, through our lens, we say, okay, we'll help children. Because children aren't able to make certain decisions. They either don't have the mental capacity, or they don't have the understanding of rights or the accumulation of civic responsibility and duties. So
And there's
that
an innocence. There's an innocence.
yes, but only certain children have that innocence. Black and brown children don't have the same level of innocence as white children. And we see that historically, and we see that today, right? And so Dr. Sparrow is helping us to understand the very struggles that we face in healthcare then in 2009 and still in 2023 were present when this nation, when genocide was happening to the Native Americans and this nation was founding, when Blacks were being used in chattel slavery and this nation was founding. Who is deserving of help? Who's deserving of resources and who is not? And unfortunately, a lot of that has been informed by racist, sexist, and supremacist thought, right? That tier of, so think about Medicaid. When Medicaid became a policy, who's deserving of Medicaid? Again, Medicaid is help. Who's deserving of Medicaid? All right, okay, pregnant person, so pregnant women, but there can't be a family, it can't be a man in the home as Medicaid was originally envisioned, because then you're no longer deserving of help. But that's only true of certain families. In the United States, we do not believe, there is a caste system, and in that caste system, unfortunately, and it is an evil that we must confront, we do not believe those who are incarcerated are deserving of their humanity.
So I would argue that 1,000% correct. But that being said, the irony is you perpetuate the cycle.
Yes, that's
Like
where
you get, you reap what you sow.
Yes, we must interrogate the myth of who America is and the mandate for who America must become. I say the myth of who America is because here you have these people sojourning because they want, a freer society, but free for whom? And who has access to rights, right? We don't equitably distribute rights in this nation. So it creates.
We've got like 5 minutes left. We've got 5 minutes left. And there are a couple things I just want to hit quickly.
Okay.
So as a thought leader, as someone who envisions a better, a more comprehensive, a more responsive healthcare system, First, I'd like to take it for the population I have the privilege of working for every day, the reentry population.
Yes.
If you could name 3 things that, when I think of housing every day, I think of employment and training every day, I think of behavioral and medical access to behavioral and medical care every day.
Right.
I mean, just the reality that somebody in prison, if they go to a hospital, they give up their cell and they have to start all over again. What are the 3 things that you could advocate or fight for in terms of reentry healthcare?
Access to health insurance.
Amen.
Governor, I mean, there's so little we can do unless.
Oh, and I see it every day in terms of drug addiction. When people don't get their Suboxone, they cop and they use and they overdose.
Yes, right.
I just had a friend of mine tragically die last week. He was 3 years sober. He couldn't get a script Suboxone. He copped some dope, 1 bag, overdosed and died. And to me, it's insane.
It is. It's mind blowing. And that is so important because I first began to understand how insurance is used to lock people out of full access to life potentiating and life affirming resources when I was uninsured. I was a physician who was uninsured. This is prior to Obamacare, because I could not afford insurance because of my pre-existing conditions. So here you had a woman who knew better, who got hurt in a very public arena. I bless her soul. I was a guest of the then Speaker of the Assembly, Sheila Oliver, now Lieutenant Governor, and she took me to an event with her. I fell off of a stage and I suffered a concussion and I twisted my knee, and I'm screaming, "Don't take me to the hospital!" And people are like, "Dr. Chris, you have to go to the hospital." I didn't have insurance, and I said, "I can't afford this." They were like, no, you have a concussion. Everyone heard your head hit the floor across this room. So imagine, I am a woman who still had a certain amount of agency. Imagine someone who is re-entering society, and society has in stripping them of humanity, has oftentimes stripped them of agency. And when they do not have that do not pass go card, that insurance card, they cannot access the services to sustain and potentiate life. Right. So one,
So health insurance,
health insurance,
give
two,
two or three.
wraparound services. This again is whole person care. You cannot just think about a person's clinical needs, right? And then we think we've grown so enlightened because under clinical needs, we're finally thinking about things related to mental and behavioral health as well as physical health. We have to think about all of that person's needs. Do you have a place to be safely and humanely housed? Are you able to eat? Are you able to get around? Is there access to transportation so that you can do these things? And when we don't have appropriate wraparound services, people continue to fall through the cracks. There's another word for recidivism, is falling through the cracks of an unjust and unfair system. And reentry doesn't start at the day that you are reentering society. Reentry actually needs to start at the day that you are incarcerated.
And three?
And three, wow, three
is community. To me is,
yeah, I was going to say three is
I think of what your brother does every day. You need to belong.
Three is getting at, we need to have, I have to give him credit, the dean of NJIT. He said that so often we talk about these skills as soft skills when they're power skills. We have to be able to empathize. We lose our humanity when we can't empathize. Community works when we can empathize, when there aren't certain people deserving of help and other people not deserving of help, right? So we need to cultivate a radical empathy and a radical love for one another in community. And we need to ensure that a community has appropriate access to power. So power can look like capital, power can look like resources, power can look like rights, because when community doesn't have appropriate access to power, community cannot take care of itself in the most proactive and steadfast way.
Responsive way. And we always talk in reentry about radical hospitality.
Yeah,
right.
That's it.
So I'm getting flagged by Cristobal, but I just want to say thank you to the great Dr. Chris Pernell, a thought leader, a visionary, an apostle of change, a compassionate and wise physician, a loving and caring person. And I'm just really honored that you joined with us. Thank you, Doctor.
Thank you.
Godspeed, my friend.
Same to you.
Thank you. God bless. Thank you.